It's my pleasure to introduce Dr. Nancy Bennett. Is the director for the Center of Community Health, also an associate vice president, and a professor of medicine of community and preventative medicine at the University of Rochester Medical Center. And what I find intriguing, want to hear more about, is she is also the deputy director of the Monroe County Department of Public Health in Rochester, New York. So we're talking about a very unique interface between public health and clinical research. She's led many studies and many community interventions related to the prevention of communicable as well as chronic diseases. And she is the director of the Community Engagement Corps of the Rochester CTSA and their Clinical and Translational Science Institute. She's a board member of the Association for Prevention of Teaching and Research, for Prevention Teaching and Research. She's a member of the NIH Clinical and Translational Science Award Community Engagement Steering Committee at the national level and serves on numerous local and national panels and advisory groups. She's a graduate of the New York University School of Medicine, did her residency and chief residency at Bellevue Hospital in New York City, near and dear to my heart. And during her fellowship in general medicine, where I am told she sat in a chair next to Paul Morantz in introductory epidemiology at Columbia Presbyterian Hospital, she earned a master's degree in epidemiology. She was an assistant professor of medicine, a Mellon Fellow in epidemiology there, and taught in the School of Public Health at Columbia before moving to Rochester, where she became the head of the Division of Clinical Epi at Genesee Hospital before joining the Department of Public Health in 1992. So she's been public health for quite a while now. And she returned to the University of Rochester in 2006 as professor of medicine and community and preventative medicine. I think she has a great perspective. I think she's a great speaker to kick off the CTSA focus on community research and remind everybody that is one of the main focuses of that process, of that grant. So please welcome Nana, as I'm told.
Thank you very much. It's really a pleasure to be here. I want to thank the organizers of the conference for inviting me. I love to come to New York, as Paul knows well, and to have a professional reason to come to New York is really a thrill. So thank you so much for inviting me.
This will advance that. We'll go back.
Oh, okay.
I'm going to point to you if you like.
Okay, great. Thank you so much. So today I'm going to talk to you about what I refer to as the last step, and sometimes I refer to as the terminal step, which isn't exactly what we want to think about. But Kevin Grumbach, actually at UCSF, has termed this the roadmap less traveled. And that's exactly what I think we're going to talk about today. And I'm really here to convince you that if we don't do this well, we might as well not be doing any of the rest of it. And it's really critical that we start to figure out how to do this last stage of translation, or really much of the work that we're doing will go to waste. And this is a hard thing to convince you of immediately after lunch, and I'm a little bit worried about that. And it's also, I think, a hard thing to sort of shift gears totally from the very exciting morning presentations we heard. But I got a little help from my friends, and we did already sort of begin to broach this area. And I'm going to step back a little bit more into the academic side of it, but I hope I won't put you to sleep. And those are all the bad news. The good news, I think, is that as Nir described, I am from one of those families with the longevity gene, so I have a long time to convince you of this. So we're going to be here for a while. I hope not too long, really. But what I'd like to do today is talk to you a little bit about some background. Why do we care about this so much? Why is it so important? Why does it matter whether we do the last step of translation? Then talk a little bit about, explicitly, about the NIH Roadmap and the CTSAs and sort of how they're structured. And then I want to talk about Community Health Improvement 101, because I don't think you can talk about translation without understanding community health improvement. And then lastly, I'm going to use the Rochester example, and I hope that you won't be bored by my using the Rochester example. You know, it doesn't always snow there. It's actually kind of nice. But the reason I'm doing that is because I think by using our example, I can highlight some of the key themes that I think are important as we start down this road. So why are we doing this? That's really the most critical question. And I think this slide speaks for itself. If you're not familiar with disability-adjusted life expectancy, it's basically a measure that brings together many, many, many other measures of health status into a single number, if you will, which is disability-adjusted life expectancy. And, you know, one can quibble about all the specifics that go into this, and one can, you know, say, well, that doesn't really count and that's not important. But, you know, it's pretty hard to look at 15,000 indicators of health status. So it's very useful to have something that sort of pulls those together. And as you can see from this slide, we're not doing so well. And no matter how you slice it, we're not doing so well. There may be a few ways in which the United States might get into the top 10, but in vast majority of health status indicators, we don't. And I think the take-home message from this slide is that we're all moving to Andorra, right? If you know where that is. So the other problem, obviously, and we're all familiar with this, is the incredible increasing rate of our spending on health. And as you can see from these two slides, the first one, these two graphs, the first one is, you know, can I use this? I'll use the pointer. Okay. So as you can see from this first one, this is the average spending on health per capita in the United States, and this one is just total expenditures as a percentage of the gross domestic product. And you can see the take-home message is the same. But what's really disturbing is not only do we spend more than everybody else spends, no matter how you measure it, but in addition, the slope is really tremendous. And the slope is increasing quite rapidly. So we know we have a problem. And this was clearly not lost on either any of us or on the NIH. And our problem is multifactorial. It's not something that we're going to solve with a magic bullet. It's not even something you can say, you know, oh, that's the problem. It's a number of different factors that have come together to really challenge our health system and to make it so that we're not getting the results that we should be getting. And, you know, these are the sort of typical things that people talk about why we have a problem. And I think we all agree on many of these things. But I think that the last on the list is really what we're here to talk about today, which is our failure to implement scientific advances. And I would propose that there are a whole series of reasons for that that relate to what we're talking about today, and that we really need to be very attentive to this last. Now, you can argue that the bigger issue is the focus on technology rather than focusing on health promotion and prevention. And I think that's a critical player as well. I mean, I wouldn't do what I do if I didn't think that was a critical player. But I think that the last is a way to address the question of focus. It's really a question of thinking much more scientifically about what we're actually doing in our communities. So one of the things that is important is that we think scientifically about causality. And we really try to be attentive to why we might or might not have a good health status in the United States. And this is adapted from Schroeder, and I know you all read this article, right? Yes. This article was published last year, and it's basically an article that said the same thing that those of us in public health have been saying for 20 years. But thank God Steve Schroeder finally put it in the New England Journal. So now we are all feeling much happier. But essentially what this slide shows us is if you look at the determinants of health in the United States and you really try to parse out why things are the way they are, we're kind of missing the boat. And the reason we're missing the boat is that probably 40% of the determinants of health are behavioral. An additional 15% are related to social circumstances. And you know, that's really environment behavior, right? Those are two of the critical issues. Now, We heard a lot this morning about genetics. I was going to say the other good news is I'm not going to talk about genetics. But we heard a lot about it, and there's absolutely no question that it's also a critical determinant of the health status of our country. But it's not something that you're going to be able to do anything about tomorrow, nor is behavior or social circumstances. But we have a little bit more hope, I think, in having an impact if we pay attention to these issues. So what that implies also is where should we be spending our money and paying our attention? And clearly, it's not just in the healthcare system. This is adapted from a slide that I saw when I was in medical school, which I think has been updated, thank God, since then, but that really looks at the issue of where people receive their care. And it really showed that, hospitals were a tiny percentage, and then there was a slightly bigger percentage in ambulatory care, but the really tiny percentage was in academic health centers. But this is an adaptation that I developed to really look at where we should be putting our attention if we want to address the health status of our communities. So all this says basically is that hospital care, while an important component of health status, is not the full game. And if we focus all of our attention even on the medical care system itself, and I showed you on the last slide that medical care really only accounts for about 10% of the health status of the community, we will miss the boat, again, if we spend all our time, energy, resources here. And guess what? That's what we've been doing in the United States, for the most part. We've been putting all of our resources into this. And more importantly, all of our brain power. I mean, I don't even care so much if we spend all our money there, but we basically don't pay any attention to what's going on out here. Very, very little attention, increasingly now, but we understand so little about the impact of the environment, particularly the social environment, and we understand so little about behavior and how to change behavior. So we have to start paying attention out here. And that's also part of the reason why the CTSIs are so important, because it's a way to start asking these questions and to pull in the community and to really start thinking about how to get out into the community as well. So that brings us to the roadmap. And essentially the question that we are proposing is how can we restructure the research enterprise to improve the health of our communities? And I didn't make this up. It really was one of the concepts behind the roadmap, which was that we were not transforming human health, doing business the way we were doing business previously. And so there are really three key themes, and I know you've seen these before, but I thought it was important to remember that these are really what we're trying to work on. We're trying to create new research teams where we actually meet across the institution. Those of us who've been hanging out in the community for all these years actually come in and talk to the basic scientists. We're also trying to create new pathways to discovery. So how do we make that map go in the right direction? And we talked about that this morning. And then lastly, re-engineering clinical research. So these are all critical parts of the way we're going to get from here to there. This is similar to, I think you already saw this slide, Paul showed this slide. This is just another version of it. But this is sort of the classic conceptualization of how the research enterprise works. I have a slightly different conceptualization, which is pretty simplistic and doesn't use any T's. And I actually like Paul's very much, but I've had difficulty with the T1, T2, T3. I think it's kind of not very meaningful to the outside observer. And so I try to just talk about translation, and I try to talk about translation at whatever level we happen to be at. So this is just a different way of looking at it. But I think what's important here is to start to understand what happens down here. And that's obviously what I'm talking about today. How do we get, we're doing a pretty good job, I think, of thinking about this. I have to tell you, when we went to the NIH for the very first meeting of the CTSAs, it was the 12 community engagement directors from across the country, and we all got in this room, and it was clear we all had different concepts of what this meant and different things we were doing and so forth. But the really funny thing was that the NIH folks said to us, well, we just want you to know that everybody else has met, all the other teams, and they're leaving T2 to you. So it was sort of daunting. But I think that it's also realistic, which is that academic health centers have not been engaged in this typically. It's really been isolated in little pockets of academic health centers. I mean, there have been departments of family medicine, there have been general internists, there have been departments of community and preventive medicine, but really the institution has not seen this as part of their mission and really has not understood the critical relationship between academic centers and their communities. And it's something we've been harping on in Rochester for many, many years, and my particular version of that has been pulling public health and academic institutions together. But I think across the country we're really seeing a lot of different models develop, and I think the critical issue is that we need to understand the role of the community in all of this. So if you think about how interventions impact health, and this is again just another sort of simplistic way of looking at it, but I think we do clinical research to determine efficacy, we get something licensed, we disseminate it to the medical community. Actually, I had a great discussion with Bill this morning about dissemination and how if you develop something that, 750 people need across the country, you can probably disseminate it really, really well. But it's a little bit harder when we're talking about broader dissemination. And we know that it's really critical that we do these effectiveness studies, and we actually do a lot of those in my center, where we look at sort of post-licensure effectiveness of things. And then, we develop evidence-based guidelines, which are very critical for the practice of health, of medical care. We implement things in practice. And then we try to think about, well, how does this apply to the community? So let's say I've got this great vaccine, right? You know how we go through all these steps. You've seen that. You've seen the studies. We know how to do that. But what do I do when I get down here and I can't get anyone to give this shot? I mean, HPV is a really great example of a wonderful vaccine that we're all incredibly excited about. So how do you get adolescents into your office to give them that shot? That's pretty difficult, actually. And then how do we get adolescents to want that shot? And how do we talk to their parents about it? So there's obviously a lot that goes on at that point. And that gives rise to a ton of research. And I think that's what a lot of us are coming out of the woodwork saying loudly is there's really a lot of research to be done, and it's really interesting research. And we hope that the young trainees that get involved in the CTSAs at their institutions will start to think about this end of the research spectrum. And coming from public health, I'm begging you, public health needs this research desperately. Public health has no resources to do this kind of work. None, zero, zilch. And until it gets done in the academic institutions, it's not going to happen. And we're still going to be really, really hindered in our capacity to actually improve health. So this is a nice list of different kinds of research that was published in JAMA not too long ago. And I think it's just at the tip of the iceberg. There's lots of other work that we could all be doing. So the NIH created the CTSAs, as you know, and this is a pretty slide from the NIH, I think, sort of showing the overlap and the concept of having all of these different groups together to provide infrastructure for changing the way we do research in academic centers. And I think that one of the critical issues, and this is not just for community engagement, this is across the board, is how well are these institutes going to be integrated into the academic medical centers. So is it going to be just another grant, just another GCRC? Is it going to kind of sit out there by itself? Or is it truly going to change the way we do business? And is it really going to have a long-term effect? And that obviously remains to be seen. But it's really critical to those of us who are involved in this little part, the participant and community involvement, because our sense is that this is our opportunity. Like if we miss this opportunity to really redefine the relationship between academic centers and their communities, we will have missed the boat. So it's very critical timing. So this is the Rochester Clinical and Translational Research Institute, and you can see that we have all the same core functions that everybody else does with community engagement down there, because that's what I'm going to talk about today. But I just want to use it as an example, again, of showing the breadth of the kind of infrastructure that academic centers are hoping to develop. And I can tell you, as one of the first awardees, and so we're in our third year now, that it really has been transformative for our institution. there have been a huge number of changes that have occurred in the way we do things, and it may be regulatory, it may be who talks to whom, it may be how we give out funding. There's just a whole series of changes, not the least of which is that we all sit in the same room once a month, which is pretty amazing. I mean, I know lots of people I would never have known, and we actually call on each other for teaching opportunities. We do, we're starting to do more and more work together. So I think it is transforming if we use it the right way. So let me turn, before I talk about our community engagement efforts, let me turn to talk a little bit about community health improvement. Every time I say I run a Center for Community Health, someone says to me, well, what do you mean by the community? And I, sometimes find this a problematic question, but I think it's one that's worth asking. So how do we measure community health? First of all, I'm somehow missing a slide, but I will just forget it. Okay. These are the leading health indicators from Healthy People 2010, which I'm sure you've seen before. But Healthy People 2010 is one way that we think about the health of the population at a national level. And as you know, it's a big compendium of lots of data that tells us lots of things about the health of the nation. But it does give you sort of an idea of how we think about community health improvement. But before we think about the measures, we also need to think about the definition of community. So the definition of community, I think, really depends on the goal of the research or the previously defined partnership. And what I mean by that is, on the one hand, your community will be defined by what you're seeking to understand or learn. But on the other hand, it might be defined by who you work with. And this is one of the concepts of participatory research that we really have not yet fully incorporated, I think, which is that we may start out with a community partnership and then move into our realm of interest rather than the traditional, which is that the investigator has a great idea and finds a community to do it on. It may be defined by a geopolitical area, and often when that's the case, we're focused on subgroups. So in Rochester, for example, where we have a very impoverished inner city with tremendous health disparities, we focus a lot of our attention on the African American and Latino populations. But in other areas, it might be some other group that you would be particularly focused on because of the disparities. We may focus on people with a particular demographic profile, particular risk factor, a particular condition or disease. For example, we're now beginning to do some work among pre-diabetics. So the question becomes, how do we identify pre-diabetics? How do we work with pre-diabetics? If they are going to be a population we want to work with closely, we need to figure out how to engage them. We often start with a broad focus, but then narrow it down. So for example, if I want to improve the immunization rates across the entire community, I may start with the community, but then the studies, and I may actually measure my ultimate outcome by the community measures, but I will then probably narrow it down to figuring out the best points of research within that community, the best places that I can go to understand better how to increase immunization rates. And then finally, one of the biggest issues, I think, in doing community work is that your partners need to represent their community well. And this is a very tricky issue in most communities, because if you're lucky enough to have some kind of leadership organization so you actually know who to work with, what you don't know is how well they actually represent their community that they are telling you they represent. So we have to really engage in a very honest dialogue with our communities to understand who they represent, who they might not represent. But when there are community structures, you don't want to run around them. You don't want to be the academic center that says, oh no, you're not a good enough partner, I'm going to run around you and go to somebody else. But we find this a fairly complex question. So community health improvement is basically the concept that we're really going to improve the health of the community as a whole. And obviously each individual's health will improve, but we're going to measure our success based on the population. And that's really where we need to get, because we need to assure that we're really moving the health of the entire population. And this is not just because we want to look better on that list I showed you. It's also because we want to stop spending money where we don't need to be spending money. We need to really look at the big players and try to address them. But the tricky thing is that it really requires a consistency of goals and approaches, and that can be very, very difficult. The academic health center doesn't traditionally align its goals with those of the community. I don't think that your CEO goes out to the community and says, what do you think Einstein ought to be working on? Now, maybe I'm wrong, but that would be an unusual academic health center. I think that's going to happen, parenthetically, because I think that increasingly the state government, the national government, there are pressures being put on not-for-profits to actually demonstrate community benefit. And as a result of that, I think we will see more of the CEO saying, what do you want me to do for you? But I think it's a new paradigm for all of us to really start to think about how we can play a critical role while being essentially respectful of our communities and understanding our communities' needs. And the other reason that academic health centers have a critical role to play is that you've got all the expertise. I mean, we have huge expertise, and we need to use that expertise in our communities. I think there's been a lot of change in focus and a lot of change in understanding about our role in the community, but we still have a long way to go. And I think that academic medical centers are leaders. They're leaders of the whole healthcare system in a given region, and they have a tremendous role to play in terms of resources and expertise. So, I think I moved that slide. So that's why it's out of order. So I just wanted to mention, we talked about measures a little bit. I want to give you one example of the way we address this issue of community health improvement in Rochester. And it's just one example, but it highlights the important pieces of all of this. And this is a system or a process that we started about 10 years ago, I think more than 10 years ago, when the health department sort of realized that if it wanted to do quality improvement, it had to really create a process across the whole community to do that. And so essentially the critical elements of this process are assessing health status. And here's a little bit where I kind of differ from the traditional CBPR approach, community-based participatory research approach, or the traditional approaches that have been put out there from some of the national organizations, which really focus on the quality of the partnership with the community. Well, I think that we also have something else to bring to the community, which is our expertise in being able to define the critical health problems of our community. Sometimes, and I'll show you our list, and it's complicated, sometimes those problems that are identified by the community as their critical problems are not really the big players. And we have to sort of be sensitive to that and respectful of that, but we also have to bring our expertise to the table. There's no reason for you to be at the table if you're not going to be as smart as you can be. And so if you're an epidemiologist, you owe it to the community to say, okay, I know violence is a big problem, and I know that we need to talk about this, and I know that that the perception is the reality, and we can work on this together. But I also want you to recognize that our diabetes rates have doubled in the last 5 years. And all we're asking is that we engage in a dialogue, and that we make sure that everybody brings all of their expertise to the dialogue. So rather than saying, I'm here from the university and I'm here to help you. I used to say that when I was in government too. Rather than doing that and kind of having a paternalistic attitude towards how, if you tell me you want to work on this, I'm going to work on it because that's what I'm here for. Instead, we need to be totally mutually respectful and really sit together and talk about what the community problems are. The rest of this is kind of a typical quality improvement cycle. There's nothing really weird about it except that we've applied it to the health of the community. So essentially choosing priority goals, defining leadership, developing improvement plans, performing interventions, and measuring the impact. Public health doesn't do this typically, and that's why it's so critical that we all work together to do this kind of thing. Public health has almost no resources to do this part, measuring the impact, and increasingly very few resources to even do this part. So that's another reason why academic centers have to step up to the plate. Many public health departments have no chronic disease initiatives whatsoever, chronic disease prevention initiatives. You live in a city which is doing much better than most public health entities, but it's something to keep in mind. So We do this by breaking it down into a series of report cards and data collection methods. We collect a huge amount of data, but we also send it all back out to the community, so it's readily accessible to anyone who wants to see it. And then we establish, as I mentioned, health priorities that we work on together. And this is just an example of what the health priorities are for maternal, child, and adolescent. We're in the midst of the process for adults. This is our second time around for adults. So I'm not going to show you the laundry list. But this gives you a feel for the kinds of priorities that the community defines. And the way the community defines these is that we take all these data that we collect and we take them all out to the community, and we have literally hundreds of sessions with community members discussing what we found with the data, showing them the data and saying, what do you think about these data? You know, what does this make you think of? What do you think we should work on as a community? And we ask them to actually rank goals for the community. And so we rank them with respect to their importance, and we rank them with respect to our capacity to have an impact on them. Because there's no point in setting a priority we can't have any impact on. So that's just our particular way of doing this, but there are lots of different ways of doing it, but the one thing that's critical is that you do it, because you really do need to get community input on what you're doing, and you also need to share your expertise in defining what's going on in your community. So now I'm going to turn to talking a little bit about our particular approach to community engagement in Rochester, and I just thought I'd spend the rest of our time on that. Essentially, we think of it as two things, reaching in and reaching out. Reaching out is sort of the traditional part that I know everybody's really conscious of, and we talked about a little bit this morning. How is the academic center really going to partner with lots of different organizations in the community? But reaching in is equally important, and I hope I can show you that. So these are our overall aims and goals. I'm sure they look very similar for Einstein. There are sort of several different components. One has to do with the reaching in, reaching out, and partnership building. Another is really related to provider participation. We're very interested in practice-based research networks and developing capacity through those. We also are very involved in improving the capacity of our investigators and students to relate to the community, which is a little bit complicated. And then lastly, really kind of one of our key ways of measuring our success is to look at the diversity and recruitment. Our model of engagement is pretty simple and pretty obvious, but we sort of treat our providers as another community and our investigators and students as another community. So we're really three communities trying to come together and create synergy. The main structure that we use in Rochester is to have an overarching community board. And I know that, you know, this is a difficult area because, again, who represents the community, who should you have at the table? But the University of Rochester, up until this time, had a board of the university that was made up of really business people. There was no board that really brought the community voices into the medical center. So we now have a board, and our CEO attends this board meeting regularly. It occurs quarterly. Our dean comes, our dean of the School of Nursing comes. A lot of the leadership come to listen to what the community has to tell us. And they actually advise us not just on the CTSI, they advise us on a lot of other issues, and I'll say another word about that in a moment. We partner directly with a series of leadership coalitions in our community. You may be surprised to see the Deaf Health Coalition. We mentioned before, you know, what's the community? Well, it turns out that Rochester has more deaf and hard of hearing people per capita than any other city in the United States and possibly in the world. We don't really know. As a result, we have a prevention research center that focuses attention on the health of this population. So that's one of our key partners. And then, as I mentioned before, the African American and Latino communities are very well organized and have health coalitions that we work with very, very closely. Health associations collaborative is a way to bring together all those voluntary organizations. You know, every community has them. The Heart Association, diabetes, lung, etc. So we've managed to create some organization because they are really a critical player in clinical research for lots of obvious reasons. And then Health Action, which I've already told you about. On the other side, which I'm going to talk about in a minute, is our internal structure. So this is reaching out, this is reaching in. And then I'm going to talk for a moment about the glue that holds all of this together. So our Center for Community Health was established a couple of years ago and is overarching for the entire institution. So we actually, although we have our own research programs and our own community interventions that are housed in the center, we work very, very closely as a yenta, basically. We make lots of marriages. We find investigators and we wed them to community members and vice versa. So the community has one spot to come to us, and investigators have one spot also to get out into the community. So we really try to simplify things for people, and we work with all the departments and all the centers across our institution, which is not a huge institution, but it is large enough that, you know, no one knows what anyone's doing in a different department. So we try to really bring people together as much as we possibly can. And again, we are really guided by our community board. We're also in a special partnership with the health department. So this was originally established as an explicit partnership between the health department and the university. And we also obviously have a special relationship with our Department of Community and Preventive Medicine. So the center is actually located in the community, I'm happy to say. We were not initially. We were actually spread all over town. But now we are actually in the community at a place where people can actually come to see us, and where we have very welcoming offices. We also have started a community resource library, which is very focused on not only, and someone raised before the question of health literacy. Our library is focused not just on health literacy, that is sort of the traditional, you know, what do you know about health and how do you use the healthcare system and so forth, but very focused on research as well. Much of what we're really trying to do is draw that line of sight between research and better health. Better health for the individual, better health for the community. And so our library is really oriented towards that. We're also a site for community meetings and for research recruitment as well. We have a director of community health partnerships who is sort of the advisor to the rest of the institution when someone wants to create a partnership out in the community. We also have community navigators who represent specific populations and really are very, very helpful. And then we also provide a lot of the showing up is what's important. So we go out in the community and we actually represent the medical center on lots and lots of community boards, community coalitions. We spend a lot of time out there showing up. And that turns out to be critically important when you're trying to think about developing shared research. You've got to be in the room. You have to understand what the issues are. This is just to show you quickly, this is our library, and we actually have, you know, decided that we actually are in the 21st century, and so we have a direct link between our library and the medical center library, and anyone can come into our offices and talk to a librarian at any time to ask any question, and they're actually on the screen. We have webcam connection, so it's kind of an exciting new way to reach out to the community. So basically, in terms of our reaching outside, we mentioned the community board before, and I just want to say a few more words about that. So the center is kind of the glue, and then we reach out by working very closely with our community board, which provides guidance to the medical center across the board, not just to the CTSI and not just to any particular project. But this community board affords us the opportunity to take all of our research that impacts the community to them and get their input. So it is not a participatory kind of committee, but it is a place where research can be reviewed for its sensitivity to community issues and for its capacity to really engage with the community. And we also are able, through that, to have a direct link to many different organizations in the community and the coalitions. In addition, the board determines the research priorities and the principles of engagement. How should the academic center be engaged with our community? And then finally, as I mentioned, they provide a lot of input. And what that means is we now have sort of subcommittees for lots of different studies. So for example, Rochester just became a site in the National Children's Study. Well, the National Children's Study demands that you have a community advisory board, so let's not reinvent the wheel. Let's use the board we already have. Just quickly, these were, I mentioned before, the issue of priorities. These were the research priorities determined by our community board. And these were the research principles. And I just want to say a word about the research principles. They are not all of the principles that you see embodied in community-based participatory research. The reason for that is that we think there are lots of studies that involve the community that are not participatory by nature. And so we were really trying to do something a little bit broader. Not every study is going to be developed by a community group. There are going to be lots of studies that are investigator initiated, but they still need to embody these principles in working with the community. And someone mentioned before the issue of long-term engagement. Another issue is the sort of back and forth communication and education. The community is angry because we're in one day, gone the next. You know, we bring money to the community, we say we're going to do all this great stuff, and then we're gone. And what we're really trying to say is, okay, that study might be gone, but we're not gone. We're still here. There'll be another study. You may have something to do with helping us determine what that next study is, that we're here for the long term. But you also have to understand that funding comes and goes and that initiatives come and go. And so we really try to create that dialogue back and forth. Another really critical thing is this issue of enhanced community capacity, which I think Hal referred to. But it's not just hiring people, it's also really building capacity in the community, and we try to work very hard on that. And then lastly, a little bit about reaching in. Our main mechanisms are through our community health faculty group. We have about 50 members of that group who meet not too often, but have subcommittees that do a huge amount of work. We also have a practice-based research network. We're working on the education of faculty and students. And then finally, provide considerable centralized support for recruitment. So this is our faculty, some of our faculty group initiatives. And one of the key things was, I don't know how you all are doing with this, but we got all done getting the CTSA and realized there was no money for T2 research, basically. So we have been pushing very hard on this. And finally, essentially what we did was we did sort of a round where we said, okay, you can only apply for this round of funding if you're doing true T2 research. I have to tell you that the vast majority, we got a ton of applications. We got 100 applications. It was unbelievable. But the vast majority of them were not community engaged, truly. They were really good projects, but we have a long way to go in getting more of our projects truly community engaged. We also are developing departmental community service and research plans. You know, as part of strategic planning, every department really has to ante up. We have the benefit at the University of Rochester that community health is our fourth mission after, you know, the traditional three. So that sort of gives us the power to say, you know, every department really has to start thinking about this. We're also developing faculty expectations and recognition for community engaged work, and this is happening anyway, I think, but we really need to push it along a little bit. And then the rest of these sort of mundane but very helpful ways to bring attention to community-focused work. I'm not going to say a lot about this. We do have practice-based research network that has been developed as a result of the CTSI. There were some networks that already existed, but they've been pulled together in a different way. There are very interesting issues raised by practice-based networks that really go to the question of how involved is the CTSI in supporting a practice-based network. Are they minimally involved? Are they just, you know, a matchmaker again? Or are they deeply involved in providing research staff? How do we address the issue of funding? Because it's obviously very expensive for providers to take part in these research networks. So even though we're all dying to get in there and do research, sometimes it's complicated. I actually talked to Jonathan this week at some length about this, and clearly the Clinical Directors Network is a great model, I think, for many people. These are just some of the courses that we've been developing. These are directed towards initially graduate students. They're actually mostly MD, MPH students. And then also directed towards investigators. These are all primarily web-based, although they all include some face-to-face component. This is the current state of recruitment in our institution. Now, I'm being perfectly honest here. This is what we do. And every grant that gets written has a little recruitment part of it. And you know, the NIH is getting smarter. Those grants are getting sent back. And I think the NIH is expecting that we start thinking about this in a much more comprehensive manner. So we have been thinking about it a bit. And we have, first of all, established some measures of recruitment. Now, mind you, half our studies don't even recruit enough people, let alone diverse enough people. But what we're trying to do is really use our data to measure our progress on this issue. We also started out with doing a lot of work both in the community and in the institution, key informant interviews, focus groups, blah, 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 to ask the community, what do you think about research? What appeals to you? What doesn't appeal to you? What about the language? And we did it in a way that was kind of very specific. So we did it in the African American community, we did it in the Latino community, and we did it in the white community. And we really asked a lot of questions that guided us tremendously in our work. Similarly, we did it within the institution and the research community, saying, what do you need? What do you not need? What's okay? What doesn't work? And basically, the take-home message from inside the institution was we need some centralized resources. We can't keep doing this. We really need to move and really become more sophisticated. So as a result, we've developed sort of a centralized consultation. Marketing is part of that. We have a users group. We have readily accessible resources for investigators if they want to recruit from a particular population. You know, what's the evidence base out there already for the best ways to do that? We also have our site as a community recruitment site, which I think will be helpful. We've just moved there fairly recently, so I can't tell you whether it's helpful or not, but we think it will be. And then finally, we're also developing a clinical research website, which probably many people already have that. You may well already have that at Einstein, but the university didn't. So we've gone from this to this, which is was studied in really great detail. We asked lots of groups, you know, what keeps you from participating in clinical research? And for the most part, the answer was I didn't know about it. My doctor didn't tell me about it. And there were also some answers about trust and knowledge and some of the things that you traditionally hear. But it was very interesting across all groups. A lot of it really just had to do with, gee, I've never thought of it. And it doesn't seem like it's for me. Can you tell me more about it? And then the really interesting thing was that what Latinos and African Americans really wanted to know was about the issue of underrepresentation and about the problem that we have in applying the results of research to African American communities when they're not represented in the basic group that the research was done on. And so we actually thought, well, gee, what about if we just say it? What if we just say, you know, people are underrepresented? You know, would that work, or would it be offensive, or what would happen? And what about if we just say, I'm Latino and I took part in a trial because I want my people to be represented? So we tried these out, and they loved them. It was really fascinating. The community really, really related, and they related. We had a whole bunch of other things that we tried out, but they specifically related to some of the faces. They also specifically related to the message. So we've changed a little. This is just our website, and which is under development still, but one of the important things is that this will enable us to be immediately responsive to the community. So as we put things like this out there and we say call this number or go to this website, we'll be able to actually deliver on the goods. And we actually have a phone number that will be answered by someone who's knowledgeable enough to use the website to be helpful to people. That doesn't mean we're not going to be going through physicians' offices and doing the usual forms of recruitment, but we think that if we can really increase awareness across the community, and this isn't going to be a big glitzy kind of thing. It's really much more of a grassroots sort of communications campaign. So I'll let you know how well it works. So I just want to summarize and say that basically I hope I've convinced you that if we don't do this clinical and community translation, we're not going to have health improvement. And really, as someone mentioned earlier, our goal that we all share is improving health. And if we can't really get things disseminated to our communities, and if we can't hear what our communities are telling us about what's really important, we're really not going to succeed. And then just a few, you know, it's critical that that our work be data-driven and also community-driven. And that bidirectionality cannot be stressed enough. We have to share our agenda. We have to share our knowledge. And finally, I think it's a hugely rich area of inquiry. It is so untapped. We know so little. And ultimately, we can learn so much and be able to truly improve health. So I thank you for your attention, and thank you for inviting me.